welcome tonight to the Q&A session on the kidney. My name is Dr. Kurtz, and the purpose of these Q&As is to address common questions that people have on kidney disease and to try to educate you both in how the kidney works, the diseases that the kidney gets, and also to help you with potentially questions you might have about yourself or your relatives or friends. And the goal is to try to maintain kidney health throughout one's life. And there are certain ways to do that. So here are two very happy kidneys. And now we'll go into some of the problems that the kidney gets over time. So you probably have heard, if some of you know or have friends or relatives or yourself perhaps with kidney problems. For the last number of years, we've divided up the function of the kidney into different stages. So the units here that you see are in ml per minute. That stands for milliliters per minute. In general, this represents how much fluid the kidneys are filtering every day. So the normal kidney filters about 100 milliliters per minute. A term for that you'll see in the medical reports now for years is what's called the eGFR. eGFR represents the same thing. It's just another term. It actually stands for estimated glomerular filtration rate. The G or the word glomerular comes from the name of the filters that are in each kidney that are doing this filtering. So in each kidney, there's about 1 million filters, and the name of these filters in medicine is called the glomerulus, and the plural is glomeruli. So eGFR stands for estimated. The E is estimated. The G is glomerular, the filter. Filtration, we're talking about the filtration of something, in this case, water. Rate means over a period of time. So we're asking how much fluid is filtered by these filters over a period of time. And you could look at how much filtration is occurring in minutes, seconds, hours, days. This happens to be how much fluid is filtered in a minute. And the average is about 100 per minute. And as this filtration declines, we have a term for that. We call that chronic kidney disease. That's what CKD stands for. And we have artificially broken this down into different, what we call stages. That's artificial. It's actually a continuum. If you have a problem with your kidneys and it gets worse over time, it's a continuum. It doesn't jump from one stage to the other. It gradually decreases from 100. It can go down to 0 where you're not filtering anything. When you get down to about 15 milliliters a minute, roughly in that range, you need to replace the function of the kidneys. You need dialysis or a kidney transplant. Anything prior to that, you're still able to stay off dialysis and you don't need a kidney transplant. And you feel generally well, and your blood chemistries, your blood tests are normal. It's only when you get down to about 15, 20 milliliters a minute, which in this staging represents stage 4 or 5 CKD, that you start ending up with the need to replace what the kidneys do. Now, the E in the eGFR stands for estimated, because these numbers that you get back that the CKD stage is based on is an estimate of what your glomerular filtration is. It's not a measurement that the lab does. We estimate the glomerular filtration rate using a blood test called the creatinine. So the creatinine is measured, and the creatinine is a test that's measured. And the eGFR, however, is not measured. It's an estimate. That's where the E comes from. And that confuses people also. When they get their kidney function tests back, they go, what should I look at, the creatinine or the eGFR? They're together. Which one do I focus on? And the answer is both. But you need to know that the creatinine is what's actually measured in your blood, and the eGFR is based on an equation that doctors came up with, because we no longer measure the true, what's called the true GFR. Now, there are methods for measuring the true GFR, but they generally involve a test where they infuse a radioactive material into your blood. Not a lot, it's not dangerous, but it sort of fell out of vogue. It also is more involved. You need to have an infusion, you need to have an IV. It's not just a blood test, and it takes time, and there have to be blood collections. So you have to infuse the radioactive material, and you have to measure blood levels over a period of time. And then based on the blood levels, one can calculate what we call the true GFR, your actual glomerular filtration rate. That sort of has not been done clinically, other than in research environments, for at least 20, 25 years. So the eGFR is a replacement for that, but it is called estimated GFR because it can be off by 20, 25%. When you get an eGFR back on your blood test and it says 80, that can be true. It might be 90. So the doctor, if they really understand the test, will not give you the impression that that's really what your kidney function is. You have to always be aware that it may be off. And so that can be an issue, because we can have someone where the eGFR comes back at 20 or 15, and we think they're getting near the need for a transplant or dialysis. But in fact, they could be far from that. Or it can be the converse. Their eGFR, their true GFR, can actually be worse than we get back from the eGFR. Unfortunately, most doctors who are not nephrologists think this is a real number. In fact, many nephrologists do also. But if any of you are patients or any of you have seen this number before, you need to be aware that it's not a true number, and it can be off. There's a range of plus or minus 10, 15%. So please be aware that if any of you do have CKD2 or 3, they've also been broken down into further subdivisions, into 3A, for example, 3B. These are all just a way of giving each of these GFRs a name. In reality, we should be saying that your true GFR is 50, had we measured it, or your true GFR is 40. To say that your CKD 4 or 3 doesn't add any new information. It just sounds more official. The true number that determines whether you're going to need dialysis or not is the actual GFR measurement. How much fluid your kidneys are able to filter every day. Now, you should also be aware that the kidney function or filtration rate normally declines with time. It's not only diseases that affect the creatinine and the eGFR. The eGFR, or the true GFR, actually declines over time normally. This is a normal phenomena. This is not a disease. And you can see that if we take, let's say, 100 or 100%, if you want to think it in percent of normal function at the age of 50, you can see by the time you're 75, your GFR or eGFR could have declined normally by 20%. Now, this can cause a lot of confusion among non-nephrologists and also nephrologists, in that, let's say your eGFR comes back at 80 and you're 75. Well, that should not be called a CKD stage. If you think about it, CKD stages, or the implication that your eGFR or GFR has decreased, should only be conveyed to a patient if it's abnormal. That's what we call in medicine a syndrome or a disease. We don't call normal decline with function a disease. So, we know that our eyesight decreases with age, our hearing decreases with age. We don't call that a disease. And it's the same thing that occurs with the kidney, although it's not well recognized. So many times patients who are 75 have a GFR of 80, and they're said to have CKD stage 1. Or if it's further decline when you're 80 or 90, goes down further, you don't really have CKD stage 2. You have a GFR that's 75 or lower than that, but it's just the normal decline with age. So I stress this a lot to people who are on the call here who are older. Make sure you're not misdiagnosed as having an abnormal eGFR or CKD stage unless the GFR or eGFR is lower than you would predict for your age group. Then you can say you have true CKD. Now, you can think that there's a problem then that still might exist with nomenclature. If I just said the normal eGFR or GFR is 80 when you're 75, and that would be typically in a younger person called CKD stage 1. Well, what if your eGFR at the age of 75 is 60? Do I call that CKD stage 2 or worse? Or should I call that a stage that's only 10 or 15% below normal? Well, unfortunately, we don't have a nomenclature for that. And the nomenclature won't incorporate the change from the 100 that occurred normally. It'll just say, okay, you're 65. Well, we look that up on our tables, and that's your CKD stage, as if you were a younger person, without even thinking that 2/3 of the fall was normal and 1/3 of the further fall was abnormal. So these are the kind of things you need to be aware of when you're looking at your blood tests. Now, if you have an abnormal creatinine or you have an abnormal eGFR or GFR, and it's a true abnormality, you need to track that with time. Many patients, we say to them, what's your creatinine? They go, I don't know. I'll look it up. You need to be aware of what it is, just like you're aware of your age or your weight, because you need to mentally track that and make sure that it's not decreasing with time. It's not something that you should just think about once when you have your blood test done and then ignore and have to look it up. Many people forget that the blood test is even called creatinine. If you have an abnormal creatinine or eGFR, that has to be imprinted on your mind. You need to be aware of what it is, make sure it's not decreasing, constantly follow it up, so that you ensure that your kidneys stay above the threshold needed for what we call renal replacement therapy. You don't want to have to go on dialysis or get a kidney transplant. So what are the things that occur when your kidneys don't work anymore? But when I say don't work anymore, I mean that the filtration rate is down to 15 or 20%. Again, we have a big backup. We have a big leeway. Even if I take out one kidney, my eGFR is only going to fall to 50. I'm still way above the 10 or 15 level that you need to think about when you're making the decision whether to go on dialysis or not. So the kidney gets rid of water. And so if the eGFR gets down to this level, you're going to start retaining the water you drink, and the water goes where gravity is. You stand all day, your feet are going to start getting swollen. When you sleep at night, the water redistributes centrally, and then you excrete it eventually. And your ankles in the morning are not swollen. They tend to increase during the day just because of gravity. The fluid pools in the lower part of the legs. A symptom that is not as predictable is the fact that you can feel nauseous, and that is oftentimes misdiagnosed, except for the fact that it's chronic. It doesn't go away. It's not like food poisoning or a stomach virus or something that might affect, make you nauseous. This is something that's there all the time, and you don't feel like eating. You have a loss of appetite. So this chronic, constant feeling of nausea and loss of appetite, the doctor or the patient, if they know about the issue, should think that it could be due to a kidney problem. But unfortunately, it's misdiagnosed. As you can imagine, a lot of people think it's a stomach virus or something going on with the stomach. It has nothing to do with anything going on in the stomach. Nothing is found in the stomach. It's your abnormal creatinine and eGFR that lead to chemical changes in your blood that affect the brain and make the brain create the sensation of nausea and loss of appetite. The other thing that occurs is the kidney is a key regulator of your blood pressure. And so if you get severe kidney disease, your blood pressure goes up. It's a chicken and egg scenario, because some of the causes of high blood pressure can also affect the kidney. For instance, when blood vessels are very severely impaired in diabetes or other conditions, the blood vessels in the kidney also can be impaired, and that releases hormones that can raise your blood pressure. It's also more complicated than that, even as far as chicken and egg, because there's some evidence that a high blood pressure by itself, even if it has nothing to do to the kidney causing it, the high blood pressure itself might damage the blood vessels in the kidney. It's certain that a high blood pressure can lead to a stroke and also can make the heart muscle get much, much bigger, which can lead to impaired cardiac function. So high blood pressure per se has what we call end organ damage. And it's a little bit controversial as to whether the kidney is one of the end organs that can also get impaired when you have high blood pressure due to a non-kidney cause. But as far as the chicken and egg, if you have kidney disease, that in and of itself can raise your blood pressure. Anemia means, oh, we skipped electrolyte disorders. So these are chemical symbols. Na refers to sodium, P is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 is bicarbonate. All these are ions, or what some people call electrolytes, that are in our blood, and their concentrations can change when you have kidney disease, because the kidney is an important regulator of what the concentration of these things should be. Anemia is also something you can get if you have severe kidney disease. The kidney makes a hormone called erythropoietin, and the erythropoietin then goes to the bone marrow where blood is made. So when you have severe kidney disease, you don't only have a problem with filtering water, you also have a problem making this hormone called erythropoietin. And if there's not enough erythropoietin, then the bone marrow doesn't make enough blood, and you get what's called anemia, a term you've probably all heard of. Depression is another symptom of severe kidney disease. It's not clear why. It's often misdiagnosed because people can have symptoms that seem like depression, but when objective tests are done with, as doctors do, or social workers do, or psychiatrists do, you fill out this questionnaire, and this questionnaire then will give an answer, are you truly depressed or not? Oftentimes, even though to a lay person or to the patient's family or to the patient themselves, they feel that they might be depressed, when you do these objective tests with scoring all the different symptoms, it turns out the patients aren't depressed. So there's an overlap, and it's incumbent on the doctors to determine whether there's true depression or not, because it is associated with having severe kidney disease. The mechanism is unclear. It's probably an effect of the abnormal blood chemistry on the brain. Sleep disorders are another finding where patients don't sleep at night or sleep intermittently and don't sleep during the day. Now, it's well known that as you age, you get up in the middle of the night and your sleep becomes less complete as it is when you're in your 20s or a teenager. When you're in your 70s, you get up once or twice to go to the bathroom. When you're in your 80s, you get up 3 times. When you're in your 90s, you get up 4 times. And this getting up that's normal and going back to sleep does not lead to any no one's ever shown that that leads to any abnormalities. It's just a normal part of what the brain does as you get older, and you probably require less sleep as you get older. This is patterns that are very different. You sleep during the day, you don't sleep at night at all. The durations of sleep are all impaired, and you may feel tired in addition. So sleep disturbances are not uncommon in patients with kidney disorders. In addition to having nausea and not feeling like you want to eat, food tastes abnormal when you have severe kidney disease. Some people say it has a metallic taste. Some people say I can't taste the food at all. It just doesn't taste like it used to. It's very bland. And so what one has to do is spice. There are all sorts of things online that one can look up to how to improve the taste of food. In general, it involves just adding a lot of spices or salt to make the food better. It's a problem still. So the blood test again that I mentioned, the key blood test to remember is what's called creatinine. This is different than creatine. Creatine is another chemical that you might know from weightlifting or in bodybuilders. They take creatine. Creatinine is also in muscles, but the kidney gets rid of creatinine. And so since the muscles make it at a constant rate, the ability of the kidney to get rid of it has allow this blood test, the level in your blood, to become a kidney function test. And so if, let's say, the creatinine is 1, you have a filtration ability, you can think of it as 100% of normal. It's your kidneys are filtering normal. Roughly 1. Could be 0.9, 0.8. But if it's around 1, you have 100% ability to filter normally. If the creatinine goes from 1 to 2, you've lost half your kidney function, half the filtering ability. If it goes from 2 to 4, you've lost another half. So you can think of it by dividing this by 1. 1 over 1 times 100 is 100%. 1 over 2 times 100 is 50%. 1 over 4 times 100 is 25%. So you can see that just going from 1 to 4, even though it doesn't seem like a huge increase, well, it went up 4 times, you've already lost 75% of your filtration ability. The problem we have in medicine is that most doctors don't notice the increase from 1 to 2. Either they don't notice it or they don't care about it. And then because they don't care about it, and it's not they emotionally don't care, they're not aware that medically the patient's already lost half their kidney function. It would be as if I took out 1 kidney. That's what happens when the creatinine goes from 1 to 2. So because the magnitude of the change is so small, they go, oh, it only changed by going from 1 to 2. That's not a huge change. They either don't notice it or they don't tell the patient. And then the patient can't possibly know unless they've been reading online or they have a physician in the family or they're aware of their disease more than the average patient. The problem is if it goes from 1 to 1.2, that's already a loss of 10, 15% of the kidney function. And so if it goes from 1 to 1.5, patients have 75% of their kidney function, roughly. And that's a big loss. You've already changed CKD stages. So the biggest problem we have as nephrologists is that we don't get the patients referred to us in time in order to try to figure out what the cause of the increased creatinine was, or saying the same thing, what the cause of the drop in the eGFR was. And then because we're not there to come up with a cause, we obviously can't come up with a potential drug to slow down the progression of what's been going on. We usually are referred patients when the creatinine is in the 2s or 3s. And by then the patients have already lost half their kidney function. So this is a problem with US medicine, and not just medicine in the US, but throughout the world. And it's been going on for 40 years. And people have come up with different approaches to try to educate the PCPs to refer sooner. Unfortunately, there isn't a big change in the referrals to nephrologists. Testing is another issue in the urine, not just the blood creatinine and then the report of what the eGFR is, but we also look at the urine for what we call urine protein, and we have what's called a dipstick where we stick this into the urine, and then based on the color, it gives us a qualitative, not quantitative. Qualitative means we don't know the exact amount. It's just a rough idea. That's what the word qualitative means. Quantitative is that we know how much protein there is exactly. We stick this in and it gives us an idea whether there's protein in the urine or not. The reason this is important is the normal filters, the normal glomerulus, which is the name of the filter, again, should not let protein into the urine. If there's protein into the urine, it tells us also there's something wrong with the filter in addition to the creatinine. We should not see blood in the urine. So we look at the urine for blood also grossly, as you can see here, but there might be blood in this first tube. It's just that you don't see it because there aren't enough red blood cells to create the color. We also look at the urine under the microscope, and the doctor, when he sends off the urine, will also included in that is not just a test of the protein and other things that I'm not going to have time to mention today, but also they'll look under the microscope to see if there are red blood cells under the microscope. And there should be a few, but not a lot. In normal urine, there's always a few. A few sneak through the glomeruli, but in general, red blood cells can't get through the pores in the glomerulus, so they don't end up in the urine. The other thing we look for is infection. These are bacteria seen under the microscope. We don't just look at the bacteria. We try to see what antibiotic they're sensitive to. by looking under the microscope, we can't tell what antibiotic they're sensitive to. So we take a sample of urine and we put them on this plate, which is called an agar plate. Agar is sort of a gel, and it's also got food in it. You can think of it as solid jello if you want. It's actually a little more solid than that, but the bacteria can grow on it, and the bacteria form what are called colonies. These are thousands of bacteria. The bigger the circles, the more the bacteria. When they divide, they just make this grow and grow and grow and grow. And then the technicians put on different antibiotics. Usually they're in the form of little discs. They each have a different antibiotic on them, and they see how well they can kill these colonies. And the one that works, that's what the lab will report back to the doctor. Usually there's more than one that works, and usually there's more than one that doesn't work. And then based on that, the doctor will know what antibiotic to recommend. Now, the problem with this is it takes 2 or 3 days for these colonies to grow. If they grow, sometimes we don't get any growth, and then there's more of a problem. But it takes 2 or 3 days to get back what we call the antibiotic sensitivities, and the patients in the office with, burning urine and a urinary tract infection. Usually the patient, it's usually a young female, sexually active female, they get urinary tract infections more commonly, and the symptoms are frequent urination. They say, I'm just peeing all the time, and burning every time they pee. Well, that's a urinary tract infection until proven otherwise when you hear those symptoms. But you don't want to wait 3 days to treat the patient. They don't feel well. And so you'll just guess at an antibiotic, and then you'll see when you get this back whether you chose the right one or not. So that's the sort of typical approach, and the patients are treated for 7 to 10 days usually. Diseases that affect the kidney, I'll just mention a couple. The major one is diabetes. So if you can get rid of diabetes, you would get rid of half the kidney disease on the planet. And you would decrease the kidney transplant programs in half, and you would empty out half the patients in dialysis units. So this is the huge disease, and it's the major one, and that's why many drug companies are trying to work on drugs for it. How diabetes does it is twofold. One, diabetes ruins your blood vessels. So if you have diabetes, and not in all patients, but in a percentage of them, this is a normal blood vessel, and this clearly doesn't look normal. It's got this yellow stuff, which is fat in the wall, and blood clots can occur because the wall is abnormal. And so the diameter of this tube can get much less, and it can affect the large blood vessels or small blood vessels. So the blood flow to organs becomes impaired. And if it's the brain, you can get a stroke. If it's the heart, you can get a heart attack. If it's the kidney, your eGFR goes down or your creatinine goes up. So generalized blood vessel problems in diabetes. I mean, the layperson thinks of it as a blood sugar issue, but that's not what causes disease. It's the abnormal blood vessels that are part of what goes on in diabetes. As far as the kidney itself, there's a second phenomena that occurs in addition to the blood vessels, which occurs in all organs. The filter in the kidney gets plugged up. This is one filter. So this is one glomerulus. Remember I said you have about 1 million of these in each kidney. This is what leads to your eGFR being 100. Not this one. Obviously, this one is filtering a lot less. But you have 1 million of these in each kidney. You sum up the filtration of all of them, and you end up with 100 milliliters a minute, or an eGFR of about 100, if you want to think in those terms. Or if you want to think in percent, you have 100% normal renal function. But this is what occurs in diabetes. You get plugged up glomeruli, and you could see here that this ability of this glomerulus to filter here is not going to be what this glomerulus is. And to the extent that this occurs, it can get so bad that you have an eGFR of 10 or 15, and then you need a dialysis. You need to go on dialysis or get a kidney transplant. So when you divide up diabetes, we divide it up into those patients whose pancreas doesn't work normally and they don't make insulin and they need insulin, versus the vast majority of diabetics who are overweight. So when you become overweight, it's not that the pancreas doesn't make enough insulin, it's that insulin doesn't work as well. So as you gain weight, insulin has a harder time working, and associated with that is diabetes. The blood sugar goes up, insulin's not working as well. And the simple answer is to lose weight and get back to your normal weight. Unfortunately, humans love to eat. And if the whole world was at their ideal weight, or the weight they were, let's say, when they were 15, 16, 17, again, we would empty out half the dialysis units. But, people love to eat. And the hardest thing for any doctor to do is to have a patient change their diet permanently and get to the weight they should be at. It lasts maybe 2 weeks when you talk to the average person. And, people will say, yes, I'll go on a diet, or yes, I'll go to the gym. 3 or 4 weeks later, they're back to what they were before, either because they just couldn't do it. Eating has an emotional content, as you know. Relatives, when you go to someone's house, there's a social aspect. People eat and are embarrassed not to. But the bottom line is, if the whole human population was at their ideal weight, type 2 diabetes would disappear for the most part, and so would half the kidney disease on the planet. Another disease that we deal with, very common in Asia, is called IgA nephropathy. It's an inflammatory disorder. This is an antibody to IgA shown in the green. And you can see here the glomerulus, instead of looking like this with these nice open circles, is filled with all these blue dots. These are the nucleus of multiple inflammatory cells which are attacking the glomerulus. It's really inflamed. And the clinical correlate of this is that blood can get through here, and we see it in the urine here. This is bloody urine, and it's because of IgA nephropathy. You can get kidney stones too. These are actual stones that came out of the kidney. The stones could be of any size. If they're too big, they don't get out. They stay in the kidney. There can be multiple stones. They can be in different locations. If the stones are less than 2 millimeters, they can get out, and they go down with this pipe here called the ureter, which is the tube leaving the kidney, and they can get into the bladder, and they can eventually come out. It's excruciatingly painful when these less than 2 millimeter stones are coming out. The kidney is actually contracting. This is called the pelvis of the kidney. It actually can contract like the uterus can during birth. And it causes severe, severe pain. In fact, the pain of a kidney stone, many people say, is worse than giving birth to a child. People need morphine. This is another disease called polycystic kidney disease, where instead of the kidneys being nice and smooth and of a certain size, they get multiple cysts. Cysts are fluid-filled cavities. It's called polycystic. It means, poly means many, cystic means fluid-filled cavities. And associated with this is an abnormal creatinine and eGFR. And if it gets very severe, the patients may need renal replacement therapy, in other words, dialysis or a transplant. The gene for this is known, and there are other genes that can actually also cause cystic kidney disease. This is a young girl with a disease called lupus. You might have heard of this. It's an inflammatory condition. Again, the glomerulus shown here, this is a normal one. You might get used to seeing these now, nice open loops. This one's filled with these dark dots here. Again, these are what we call the nuclei of each cell. Tons of cells here that shouldn't be here. And these are inflammatory cells. This whole glomerulus is inflamed. It doesn't just affect the glomerulus, it can affect all organs: brain, heart, eyes, liver, all the organs, muscles, all the organs in the body. The blood vessels under her skin are inflamed and dilated from the inflammation, and they're letting more blood through than normal. That's why you can see this. This is not a rash in the skin itself. These are the blood vessels under the skin that are dilated, and it's shown here just as what we call erythema, or redness. Usually it occurs in young females. Their skin is more sensitive to light. They can lose their hair, and sometimes it gets so severe that people, again, have a creatinine which is too high with an eGFR that's too low, and they need dialysis or a kidney transplant. This is cancer of the kidney, one of the rare cancers. The normal kidney looks like this on a CAT scan. It's called a horseshoe outline. This is a kidney that has cancer in it. And this is just a cartoon showing cancer in the kidney. Currently, there's about 650,000 patients on dialysis in the United States. Every year, about 100,000 patients go on to dialysis. They have CKD stage 5, which again just means their eGFR or GFR is around 10 or 15. And each year, about 100,000 people die on dialysis. So the number stays roughly the same. For the first time, actually, since these numbers have been recorded, we're actually seeing in the last half year a decline in this number. And there are many reasons people have come up with why we're seeing the decline for the first time. Some people think that there were less patients coming on to dialysis because more of these patients died during COVID. So patients with CKD 4 or 5 is one hypothesis, died earlier before getting a chance to go on dialysis. That may be one cause, so COVID. Another cause people are talking about is that there are better drugs. So the number of people going onto stage 5, CKD stage 5, might be less, not because they died from COVID at 4, but because the drugs are perhaps slowing down the progression to 5. And this would be a great thing. Another reason there's less going on to dialysis per se is that people are being transplanted sooner. They're getting a kidney transplant at an eGFR that before they wouldn't be able to be transplanted at. So this is called preemptive transplantation, where many centers are now allowing people to be transplanted at an eGFR that beforehand they would say, wait, your eGFR is too good. You have to wait. So there are a number of causes, but what we're seeing, whatever the causes are, we're seeing less patients on dialysis in the United States. And coupled with that is the large dialysis companies like DaVita and Fresenius are closing dialysis units. They don't have the same number of patients coming into their units as before, and they're losing money. So they're closing dialysis units. We had one occur in Los Angeles, and this is occurring throughout the United States. And this is a potential problem because if you do a heat map of where dialysis units are, there's an excess amount of number of dialysis units in underserved areas, in poorer areas, because that's where a lot of the kidney disease is. So that makes sense. These people don't have cars, many of them. It's very difficult for them to get off work to go to the clinic or to go to the dialysis unit. So if dialysis units start closing in these areas, it's going to cause a further social problem in the US, where these patients are going to have to find new doctors, new clinics, have more difficulty going to a dialysis clinic from where they live. So that's something that's occurring now in the United States. In the future, we're going to have not dialysis units and transplants, but we're going to have artificial kidneys and xenotransplants, which means transplants from a non-human organ. And in this particular case, it would be pigs. People are now working on xenotransplants very heavily. At UCLA, we're working on an artificial kidney. The xenotransplants are very interesting because if you follow the news at NYU in the last month, they've had this was a brain dead patient. So the family allowed the experiment to be done on someone who was brain dead anyway. They attached a pig kidney to the patient, and the pig kidney was functioning completely normally with making good urine. Creatinine was within the normal range. And this is very exciting because a lot of work was done. This was not a normal pig kidney. Many genes were knocked out. There are a number of different biological pathways that one has to surmount in order to have a pig kidney not rejected in a human. It has nothing to do just with matching, or the typical sort of word matching. There are other pathways that allow the kidney to be destroyed. But this is over the last 30, 40 years, these are being more and more understood. And eventually, I can't say when, in the next 3, 4, 5, 6, 7, certainly by 10 years, I would say, we're going to have many patients in chronic dialysis units transplanted. And most of the transplants I envision are going to be xenotransplants. They're going to be pig kidneys. The artificial kidney will also play a role at some point. When that will be available is hard to say. These projects take tens to hundreds of millions of dollars. And so most of the projects, including our own, are constantly trying to find funding in order to reach sort of the goals that we're trying to achieve. It really all comes down to a matter of funding. So I think I'll stop there. And if anyone wants to unmute, I'd be glad to address any questions that you have about the talk I gave, or I'd be glad to answer any other questions you might have.
I have a question. My name's Stuart Loeb. What is the relationship between BPD and CKD?
BPD?
Yeah, prostate. Benign prostate, BPH.
BPH, okay. Yes, so one of the ways the kidney, so when we think of how the kidney work, we divide it up into entities before the kidney, within the kidney, and after the kidney. That's how we think about it. So before the kidney, blood needs to come to the kidney. If you have severe heart failure or a heart attack, your kidney can fail. Your eGFR will be abnormal. Your creatinine will go up. Or you can have problems within the kidney, as we talked about, like diabetes or IgA nephropathy. Or you can have a problem outside the kidney. The urine has to come out of the kidney into the bladder, into the toilet. If you have anything blocking that flow, then the kidney will fail, the eGFR will drop, and the creatinine will go up. So when the prostate, the tube that comes out of the bladder, so remember, the kidneys have a tube coming out of them called ureters. They both go into what's called the bladder, which is a sac which holds your urine, right? We're not always peeing. That's because the bladder holds urine. So we don't have to pee constantly. If you had no bladder, urine would be coming out constantly. The bladder holds the urine, and when it fills up to about 1/3 of a liter, it sends a signal to your brain saying pee. But coming out of the bladder is another tube called the urethra, but the urethra goes in males through the prostate. And if the prostate, so it sits under the bladder, and if the prostate gets too big, it squeezes down on that tube, or you can think of it like a small pipe, and it blocks it. And if it blocks it severely for all the time or for a large period of time, your kidneys, the fluid, the pressure will back up into the bladder first, and then into the ureters, and then it'll back up into the kidneys, and the kidneys can fail. So benign prostatic hypertrophy is a cause of kidney failure. And so in men, it constantly has to be assessed. Whenever a man in their 60s, usually when it starts, or 70s, has an abnormal creatinine or a low GFR, we rule out a prostate problem. In women, obviously, that's not an issue. Did that answer your question, Stuart?
Yes, thank you.
Does anyone else have any questions?
Dr. Tony Litwinko.
Yes.
3 quick questions. I had total renal failure back in June, and the creatinine level at that point was like 8. I worked it down, and I think the creatinine level regular is 0.6 to 1.2.
Oh, the normal is around 1.2 is already elevated. That's, before you go on, if you can just excuse me, when you look at lab tests, they always have a range.
Right.
That's always misleading, because most of the time that range is way too big. If someone has a creatinine of 1.2, it's already elevated. The normal creatinine, if you take 100 people and you measure it accurately with an accurate machine, it's about 0.8, 0.9. 1.1 is already starting to trip the radar. For at least for a nephrologist, it trips the radar. For most doctors would ignore it. But at any rate, you said it went to 8.
It went up to 8, and then I got it down below 1.2. It's now at about 1.5. So on that scale of 1, 2, 3, 4 that you were showing, am I in a 2 or a 3?
Well, again, I want to, first of all, if I could ask you a few questions.
Sure.
Why did it go to, how old are you, and why did it go to 8?
I'm 79.
And why did it go to 8?
It was measured at 8 because I had total renal failure. I was in Cedars-Sinai for 6 days getting.
No, I didn't mean, I meant your kidney fail. What was the cause of the abnormal eGFR?
We still don't know. My urologist thinks that the left kidney is only at about a third of the size of a normal kidney now. And my kidney function, he gave me a number of 27. 7 for the left, 20 for the right.
Yeah, so again, this is sort of after the fact. So
but we don't know what the cause of the kidney failure was.
Yeah, so I thought I would just tell you statistically what the things are that we call this AKI. So this is acute kidney injury. So when you have normality and then you have abnormality and then it goes back to normal, that's nuts. We don't use the CKD scale for that. CKD means you have kidney disease that is chronic. That's what this doesn't way. So when you have AKI, which means you have a transient loss of kidney function, it's a very different set of clinical conditions, scenarios, and outcomes. So in the ideal world, when we say you have acute kidney injury, you had normal kidney function, let's say all your life, something happened like a heart attack, or someone gave you a drug and the creatinine went to 8 and you lost all your kidney function. The doctors may need to dialyze you during that time, but as they watch you, the kidney function gradually recovers. That's not a CKD issue. That's the resolution of AKI. Now, the most common reasons for this are either a drug that you were given for an infection. Many drugs bump off the kidneys, but then they recover. Or you had poor perfusion to the kidneys, again, because of an infection, which can lower the blood flow to the perfusion to the kidneys. Or you have a problem with the heart as the central cause, where you had a heart attack or something happened to a valve, and whatever it is, or the heart didn't pump for like 2 or 3 minutes, and the kidneys right away will start to fail.
Yeah.
It's intrinsic problem to the kidney, it's extrinsic, or it could be, as we just talked about, it could be the prostate, that your prostate suddenly got so horrible that it obstructed the flow. You went into sudden acute renal failure or acute kidney injury. You had, some people say acute renal failure, some people call it acute kidney injury. That's the modern term, acute kidney.
Well,
and then it resolves. When they fix the prostate, the kidneys slowly recover. Now, the key is they may not recover to normal. The amount that the kidneys can recover after an acute kidney injury episode from a drug or your heart or your prostate will vary with your age. If you're 20, you're going to recover faster than if you're 79. Or you may have underlying issues that may have underlying diabetes.
Yeah, well, I used to be diabetic. I'm now pre-diabetic. I lost about 65, 75 pounds. But I do have a tumor in the prostate, which has, the cancer has returned and it blocked the ureter. But my urologist thinks that the decline in my left kidney function has been going on for a number of years.
Well, this is another complexity. It blocked the urethra, not your ureter.
Urethra, I'm sorry. Yeah.
The ureter goes into the bladder.
Well, no, he said that it blocked the ureter, and he put a stent in the ureter.
Well, that's a separate. Well, the prostate can't block the ureter. The prostate is far from the ureter. The prostate, remember, sits at the bottom of the bladder.
Right.
Ureters come into the top of the bladder. So you have a balloon. The bottom of the balloon is where the prostate is.
The prostate is.
Top of the balloon has 2 tubes coming in from each kidney, one from each kidney. Those are the ureters. Now, if the prostate is blocked, it always affects both sides. It can't affect one side. If you have asymmetrical effect on the kidneys, we think of all sorts of things: a kidney stone, congenital. You may have had all your life a small kidney. There's many reasons for the asymmetry of the abnormal function, but prostatic problems are always symmetrical because you just think of it. You got a balloon with the air coming out and you got 2 tubes coming in the top. You can't affect one side more than the other when the pressure goes up. But that's, neither here nor there. The key point is that You said you have an eGFR, which may be different on both sides. One of them you said was what, 27, if I
The total for both kidneys was 27,
what
and the left was measuring at 7, the right was at 20.
I see. So you have this asymmetry.
Right.
The question always is, when we see that, is the abnormal one from birth?
Uh-huh.
That you can't know unless you had the measurements done
Sure.
way after the fact. You may have had 7 all your life, and it's still around 7. And the other one went from 100 to 27 from something like the prostate. But that asymmetry may have been quite old.
Yeah.
That we'll never know. We'll never know that. So the total of 27 is, again, an estimate, unless they measured it accurately. It's, if they just took the creatinine and the creatinine from each kidney, that's a little more accurate.
Well, it makes me want to go back to the nephrologist who looked after me when I was in Cedars for that period. And they did, in fact, do dialysis for 3 days.
Well, this is a typical course of AKI. You have something that bumps off the renal function, but it's transient. It just depends what the eGFR declines. Let's say I came in with a severe infection and I got this antibiotic, and the antibiotic impaired my kidney function. It may only impair it till the eGFR goes to 40.
Yeah.
Need dialysis.
Okay. I have a final question about drugs and supplements. I've been for years taking lisinopril, and I've also been taking a statin drug as well for a long time. And recently I ran across something that said that if you've got kidney problems, you don't want to take astragalus, a supplement, which I've been taking for about 4 or 5 years now.
Well, I would just say, your typical person in their 70s, I mean, everyone needs a statin. It's impossible to get the cholesterol down. And everybody should have anyone on the call know what your LDL cholesterol is. You want, 90, 80, 70, 60, 50, or 40. You want it low. The lower the as far as the ACE inhibitor, the lisinopril you're on, I'm not sure why you're on that. In certain situations, if it's for your blood pressure, that's fine.
It is.
You need to be aware that the lisinopril sometimes can actually lower your eGFR. And if you got off the lisinopril and went on to something else, your eGFR might go up to 30 or 31. It's something to think about. It also, with an eGFR at that level, can also raise your potassium level. So you have to watch your potassium and make sure that your blood potassium doesn't go too high. As far as supplements, I tell everybody, don't take any, not just anything. The question is, what is a supplement? A supplement is something that people are aware of from commercials. It's not FDA approved. There's a emotional aspect to it. People always think that the FDA and the regulatory agencies out there just aren't doing enough studies and testing, and there's all these secret things out there that can actually make life like nirvana and get people totally healthy. So people want to live long, so they have a friend who recommends something. But the bottom line is, you're potentially playing with fire, because you don't know biochemically or at a molecular level what you're doing to your body. And my general principle is, for anyone, whether you're healthy or not, don't put anything into your mouth unless you're metaphysically certain it's not going to harm you, no matter what any other human says. And since that's impossible to know, since the studies just haven't been done on most supplements, don't take the risk, because it is a risk. There's a finite risk that you're doing harm. Now, you may be doing nothing. It also may be that it's helping, but unless the studies are done, and
we'll never know.
And then the question would be, if it's so great, why isn't it a drug? Why isn't the FDA approving this? Why isn't this well known all over the internet? That, it's like when you go to Amazon and you want to buy something, you look at the number of stars a product has, you look at the reviews. Most of these things They're just being pushed and pushed and pushed. There's a ton of PR. The other thing is, because they're not regulated, you don't even know what's in them. You can look at the bottle and they can have all the ingredients, even if you're aware of what's on the label. You don't even know that that's true, number one. And number two, it can change every time you buy it. Every time you get another lot number, something else can be put in and it can still be mislabeled. You don't know what country they're being made in. So in general, don't do it.
Okay, thank you.
I've got a couple of questions. It's Alan Dowling. First one was with respect to BPH, is there anything that you can do to reduce the swelling if you have natural swelling from age? I'm 72.
Unfortunately, not. There is a drug called Propecia,
Yeah.
which is helpful. I don't know if you're on it.
No.
It blocks the testosterone receptor, which is one of the signals for the prostate getting bigger. It also has the great effect of making you not lose your hair. So a lot of men are on Propecia since their 40s, and they, it makes the hair grow back. So that's another reason for wanting to be on Propecia. I almost think it should be like a vitamin pill in men.
Yeah, I'm only on Tamsulos and Flomax.
Well, that helps with, keep the
with the function. Yeah.
You might want to talk about being on Propecia. If you still have a lot of your hair, you're still young. You're only 72. If you have somewhat of a good head of hair, you'll be able to keep that for the next 20 years, and you might grow hair back. So I would try to get on Propecia.
Well, we're gifted with that in my family. Second question was whether there's any way in general that you can restore your function to increase your eGFR.
Yeah, so this is a great question. This is the this is the elephant in the room. This is what nephrologists have been wanting to do for many years. And the answer is, in general, it's very difficult to do because it's not a blood flow issue, which that's something that's potentially reversible. There's actually tissue damage and scarring.
Right.
So that's hard to get back. In general, the answer is no. What we try to do is slow down the rate of decline. We try to slow down the rate that the inflammation and the scarring is occurring and the tissue damage is occurring. There are some new drugs out there. They're called the SGLT2 inhibitors. They seem to work in many different causes of chronic kidney disease. They actually block sugar from being absorbed into the early part of the kidney. Found actually to have this other side effect of helping with heart function and also helping prevent the decline in kidney function in people with CKD. In many different diseases, there are issues with insurance. There are issues that initially when you start them, your eGFR drops, and that scares a lot of nephrologists and patients. It comes back, though, if you just stick with it. But a lot of people, they start on the SGLT2 inhibitors and then stop it as soon as the creatinine goes up. If you just the creatinine will fall again.
And my final question is there any way to get your creatinine down? By way of background, I had end-stage liver disease in 2003, 2004, and a transplant in 2004. Doing fine since then on that. I've recovered really well. But this is a natural offshoot of that. I went through the phase of becoming type 2 diabetic, although my A1C is down to 4.9 now. But my creatinine has been elevated throughout the period since my transplant.
Well, this is a separate complex issue. And again, when you said, can you make the I think you said, can you make the eGFR better? The last question. That's the same as saying, can my creatinine go down? At least it's just like, it's the same thing because I
didn't know if there was another aspect of the
no. When the creatinine goes down, it means your eGFR is better. They go together.
Yeah.
So as I said, the eGFR is put into a formula based on what the creatinine is. So they take the creatinine and then they put it into a formula, and the formula spits out the eGFR.
All right. That I got.
Always go together. But to get to your question in your particular case, first of all, when you have end-stage liver disease, you also get abnormal kidney function. It's called hepatorenal syndrome. So many
sure did.
who have abnormal liver function. And the reason for that is not because you have intrinsic kidney disease in many patients. It's because when you have an abnormal liver, the flow of blood out of your heart gets partitioned differently than normal. And a lot of the blood that goes to the kidney normally is shunted away from the kidney to other organs. And one of the reasons is if you look at the blood vessels going into the kidney in someone with liver disease, they're all constricted. There's severe what we call vasoconstriction. And so the heart, which is actually paradoxically pumping out more blood than it does per beat in patients with disease, the partitioning of that blood to the kidney is very low. And that causes what we call hepatorenal syndrome. If we can just dilate those blood vessels, the kidney functions normally. So that's one reason why the kidney, now, if you had a liver that was put in and the liver is functioning normally, then those blood vessels should be dilating to normal, and that can't be the cause of your CKD or chronic kidney disease.
Right.
There's another potential cause, and that is you're on, or at least you were on, immunosuppressant drugs.
Yes,
And you probably still are, I would guess.
absolutely.
And those drugs can intrinsically damage the kidney.
Yeah.
They can affect the blood vessels in the kidney or the tissue. So it's most likely, unless there's something else going on, it could be other drugs you're on that can damage the kidney, but it's most likely one of the immunosuppressant drugs that chronically, and you don't have a choice, you're between the devil and the deep blue sea. You have to obviously prevent the liver from being rejected, and at the expense of accepting some abnormal kidney function. Now, as long as that kidney function is staying constantly abnormal, but at a level which is not, too impaired, and it's predictably impaired and stays at that level for the rest of your life, then there's no issue. Sometimes they have to modify the immunosuppressant drugs you're on. It might be another drug you're on. I mean, many drugs can affect the kidney. So really, you really need to, and the problem is as people age, they get what's called polypharmacy. The number of drugs that you're taking every day, can fill a drugstore. So it's the goal of a very good doctor to look at, and patients, if they're self-aware, to look at all your pills, bring them always into the doctor at least once a year and say, do I need to be on all this stuff? The problem is, unless you have a good PCP or a good internist, these drugs are coming from different subspecialists, and no one specialist knows what the other one's doing. And so they just keep adding and adding and adding, and poor patient is stuck with all these pills. I would go over all your pills with whoever you feel comfortable with and see if you need all of them. I mean, I'd say that to everybody in their 60s, 70s, 80s, and 90s, even older patients. If
I
they're
appreciate that. Actually, I'm very fortunate that I've got several excellent doctors, a hematologist, a nephrologist, in particular, who I go over these things with, who are very aware of my entire list, and we go over it every month or so.
Okay, well, it sounds like you're being well cared for.
Yep.
There's nothing obvious that's causing the abnormal creatinine. Then you can ask them, do you think it's the immune? I mean, have you spoken to them or asked them why you have abnormal creatinine?
Well, we knew that it was abnormal because of the ongoing long-term taking of the immunosuppressants.
So they do things.
It's been up well above 3 for years, and I had no CKD at that time. I only got the CKD starting a couple of years ago, year and a half ago.
What's your creatinine and eGFR now?
4.4.
4.4?
4.4 eGFR and 12.8 eGFR and 4.4 creatinine.
Okay, so well, I mean, 12.8 is getting down there. I mean, if it's, if you're sort of knocking on the door of renal replacement therapy, have you talked to the nephrologist about dialysis or a transplant?
Oh yeah.
Okay.
Yeah. So I'm with Dr. Sarkar.
Okay, yeah, she was my fellow. So
so we've got it, but I'm curious about peripheral questions like these. Anyway, if somebody else has a question, let me give up the floor.
yeah, sure. Well, hopefully I answered your question.
Yeah, you're very helpful. Thank you.
Does anyone else have a question or anything they're worried about or anything I can help with?
Can you hear me?
Yes, this Tony.
Oh, hello, Dr. Kurtz. I'm 80 years old. I am diabetic, and It's been controlled 6'1", 6'2". I've had it for about 23 years. I am overweight, and I was just recently diagnosed, maybe about 4 months ago. I was in stage 1, and now I'm in stage 3. And I don't know my creatinine level. I will from now on. But I've decided to change my diet and to stop eating meat entirely. So I won't eat more phosphorus and acid in the blood and all that sort of stuff. So I'm going to go vegetarian, and I know how to eat in a vegetarian way. I'm hoping that will help to forestall it a bit. Is that true in your view?
Yes, well, I mean, there's sort of many issues you brought up, and that is, and it comes down to the same thing again. Diabetes, most common cause. Why is it worse? And can you do anything about the progression? It's likely still the diabetes, and the question then is, what are the theories as to what makes it progress? I don't know what your blood sugar is, control of your blood sugar, that certainly has to be there.
It's definitely controlled.
Okay, you have to have your blood pressure well controlled, strictly controlled, and that's something people don't do. You need to have a good blood pressure cuff. You need to measure the blood pressure yourself. Blood pressure is an issue because there's no one number. It varies like the weather or the temperature in your house. Every time you measure it, it's a different number. It's truly a different number. It's not a constant reading. And it also varies with position. It varies whether you're lying, sitting, or standing. You need to know what your blood pressure is doing throughout the day, and to make sure, and obviously we lose the number in the middle of the night, but you need to know what it is through most of the day by measuring it 3 times a day. Measure it. If you're doing it sitting, do it always sitting. If you're doing it lying, do it always lying. But get a good idea of what it is. You should be recording your blood pressure. We don't care, at least a good doctor does not care what it is in the office. It's always high because of what's called white coat syndrome. As soon as any human, including myself, sees a doctor, you get nervous and your blood pressure goes up. So it's very important that you get good readings at home when you're relaxed, and you record them, and you're the one who tells the doctor when you come in with your Excel sheet, or you want to keep it in a notebook, what your blood pressures are doing. And then that's what they should base the treatment on. If you have high blood pressure in the morning, the pill takes time to work, so you give the pill at night. If the pressure is high in the middle of the day, not the rest of the time, you give it in the morning. These pills take time to work and last for a period of time. So a good doctor will not just want to know what your pressure is, but when it's high. The goal is to get that pressure normal, because that can affect the progression. Now, you mentioned acid. That's come into vogue, what the bicarbonate is, or pH, something I actually teach on and have done research on all my life. That is controversial still. There's an association with large meta-analyses. It's really not clear that it per se affects the progression. And I'll talk about the meat in a minute. So because of that, a lot of people are sort of holding off meat, because with the thought that amino acids in the meat and fish create acid, unlike certain fruits and vegetables that don't. They actually make baking soda, they make base. So the diets definitely have different acid producing, not the diet, different components of the diet have either make acids or base or are neutral. And so you can mix and match and decide. It may be a huge amount of overkill to do that. It's because when you do one thing, you're missing another thing. If you stop meat, well, what's your protein intake? You need a certain amount of protein so that your muscles are nice and strong, so that your back muscles are strong, so you don't have problems with your vertebra and then get sciatica or fall. I mean, everything has pluses and minuses in life. And to be draconian and just say, well, I'm stopping this, well, you have to ask yourself, what about the other side of the ledger? What bad things am I doing in addition to maybe the good things, especially if the good things are not so proven to be good? So everything in life is a judgment and a decision, and I wouldn't just willy-nilly say I'm stopping meat. There's a certain amount of protein that CKD and all humans need to be on, in addition to the vitamins and the nutritional value, in addition to knowing that it may not be making such a big difference anyway, after a ton of thinking and effort that you're going through. So in my mind, in these kind of situations where you feel compelled emotionally, or maybe from your reading, to change your diet, you need to really speak to an expert. and you can get referred to MDs at UCLA who are nutritionists and who not a dietitian, but someone who has an MD in this area. That's who you really want to speak to, and someone who focuses on the kidney. They're hard to find. Afterwards, if you want, you can email Leslie and I can send you the name of some people who are just outstanding and have spent their lives studying this. So it's a very complicated area, both from the fact that it may not do anything to the fact that you may do harm. Now, as far as becoming a vegetarian, I'm a vegetarian. And whether I'm doing anything to my health or longevity, it's not so clear, just because it's not the only thing that people do. People exercise, people are happy and unhappy, people take their pills and don't take their pills, people are overweight or not overweight. So to say that one thing is the cause of the change that you're seeing
Right.
is very difficult to do. Is it probably healthier for you? Maybe, but maybe not, because a lot of the vegetarian diets are very fatty, and then you might gain more fat.
I'm pretty aware of how to get protein. I mean, I've been interested in this for many years, and before the pandemic, I was slouching towards it. But my blood pressure is now controlled.
I'm very happy with it. You have to be able to find the protein, right?
Yes, absolutely.
So, yogurt, tofu. So the sources of protein in general for a human being are hard to find. What choices do we have? We have, milk, we have cheese, we have fish and eggs, and we have, meat from an animal. Those are whereas carbohydrates are very easy to find. So just if you look at the number of things that have protein in them versus carbohydrates and fat, it's much less. And when you go vegetarian, it even is more restricted. But it sounds like, you're knowledgeable and you know what you're doing. I would not eat the meat because you're worried about the acid load. That to me is something that you should not be thinking about.
Well, I'm thinking also like phosphorus and nitrogen and all that sort of stuff. It has a higher.
Yeah, so that's a very good point also. And we teach that. So with protein comes the other two P's, phosphorus and P for potassium. So people who have potassium or phosphorus issues have to worry about foods containing protein. But it sounds like, what's your creatinine?
I will know from now on.
What's your eGFR?
I don't know.
Oh,
I don't know.
Okay, so unfortunately, when this CKD stage was created 25 years ago, everyone started focusing on the stage they're at. What the key is to know your creatinine and eGFR. The stage is just really is a human construct. It's like calling one color green and another color orange.
Oh, I got it. A quick question.
Yeah.
I will know this very soon. But I noticed I'm Black, and I noticed that the eGFR was different for Black people.
Yes.
And I notice now that it's going to go back to just one. So my question is, if I had been on the same scale as Caucasians, would they have noticed my kidney function sooner?
Well, the reason you bring up a very complicated topic. The reason the scale was different, it was because of what I've been talking about before. When you take the creatinine and put it into the formula to get the eGFR, it was found in African Americans that when they compared it to the actual measured GFR. So when these formulas were coming out initially, no one knew whether they were correct or not. By correct, I mean, what is the prediction of the formula give compared to what the actual measured GFR is? So if you follow me. So what they did this in African Americans and Caucasians, and found that to get the true GFR, it required a different formula. When you take the creatinine, you plug it into the formula, and then you compare how accurate is that prediction. In African Americans, it was found, and that was the history of why a different formula was used. It was because the single formula didn't work.
Based on muscle mass, though.
Well, not clear initially why. There were hypotheses, but so that was the evolution. And then what people have tried to do in the last number of years is have one formula that can apply to everyone. And so that's where most hospital systems have gone to. in my world, these are still estimates, whether it's African American. What we're trying to do is come back to what we had in the 60s and 70s, and that is give each patient their true measured GFR in a non-radioactive way. That's sort of the ultimate, that's the golden fleece. So we're doing research on a new type of test with a company, and hopefully what we're going to be coming to for all patients, no matter what their backgrounds, is to come back to what we had years ago, and that's give people what their actual true GFR is and get rid of all these formulas. Because ultimately these formulas, whether you have one formula or two formulas or 10, they're just predictions. They're not a measurement. And that's something that creates an inaccuracy. Even if you have one formula for African Americans and Caucasians, it still can be off by 10, 15% in a given individual. It doesn't give you the true GFR. That's the medical point I'm trying to make tonight. And so the ultimate goal is to come up, hopefully, with a measurement like the creatinine, where it'll be an actual measurement of what that individual has. Remember, these formulas are also based on large populations of people. You don't get a different formula for each person, which is what you would have in the ideal world. We just don't know what they should be. So it's an average of, thousands of people. Doesn't mean it applies to you. So it's an issue in medicine that this eGFR has become a matter of faith, almost like a religion, when it shouldn't be. The patients and even the doctors, the young doctors, aren't aware that this has an error in it. No matter what formula we use, it's not a true measurement of what you have as an individual. So in the next couple of years, I predict one of these new tests will come on board. The FDA will approve them. The one we're working on with another company is pretty hopeful. It's not radioactive. It does require an injection, but it's a fluorescent-based method. They inject this chemical into you, and then there's a little sensor put on your skin, and over the next half hour to an hour, the device makes measurements and spits out your true GFR. And that's what we really need. And then we'll know exactly where you are. And then the CKD stage, if you want, you can say with that GFR, I'm CKD3, but it's not saying anything. It's not adding additional information to knowing what the GFR is. It's the GFR, which is what determines whether you need a transplant or not, or dialysis. It's the GFR, which determines how you feel as far as nausea or whether you're going to gain the fluid. It's something I feel, we need to evangelize the world. People focus and now all patients and doctors focus way too much on the CKD stage per se. And coupled to the fact that CKD stage is being based on a GFR measurement, which is not the true GFR. It's an estimate. So there are a number of issues that need to be corrected. One of them is to get the true GFR in all humans. And I predict, in 5-10 years, no lab slips will have eGFR on them.
Good.
It'll be your GFR. So I'm sorry for speaking so long, but I feel passionate about getting rid of the eGFR eventually.
It's good to see passion. It's really good. I'm glad.
Well, the key is that you're treated properly and that the decisions the doctors make are perfect for what you have going on with you. And that requires good measurements.
So if I email you or
yes, please, if you want, email me.
UCLA, so there'll be people at UCLA you recommend?
Yes,
for diet and nutritionist?
Please email me any questions you have, and I will get back to you with any questions regarding this or anything else that's worrying you. Just write Leslie and she'll get it to me, and I'll get back to you.
Thank you.
Thank you so much, Doctor. Thank you.
You're welcome.
Thanks very much. It's been very informative.
Okay. Good night, everyone. Have a great evening.